Hey everyone, and welcome. We're about to tackle a topic that loves to show up on exams and can be a little intimidating: zygomycosis. But don't worry, in the next few minutes, we're going to break it all down with some really effective memory aids. We'll focus only on the high-yield stuff you absolutely need to know to nail those questions. Ready? Let's dive right in.
So here's our roadmap. First, we'll get a clear definition of what zygomycosis even is. Then, we'll dig into its attack plan, the pathogenesis and who it likes to target. After that, we'll cover the clinical signs, lock down the lab diagnosis, which is total gold for your practicals, and then we'll wrap it all up with treatment and the key points you just can't forget.
Okay, let's start at the beginning. What in the world is zygomycosis? Well, you can think of it as this big umbrella term for a bunch of really aggressive fungal infections. They're all caused by fungi from the phylum Zygomycota. But for your exams, the most important thing is knowing the two main groups under this umbrella, because one of them is way more important.
And this slide right here, it's crucial. Zygomycosis is split into these two main orders. Over on the right, you've got entomophthoromycosis. It causes these subcutaneous lesions, and honestly, that's pretty much all you need to know about it. Your focus, like 99% of it, needs to be on the left side, the Mucorales. These are the guys, Rhizopus mucor, that cause mucormycosis, and that's what we're going to master today.
So how does this fungus manage to cause such a devastating disease? If you remember one word, just one word about its pathogenesis, make it this one: angioinvasive. Seriously, that single word explains pretty much everything you're going to see clinically.
Think of it like a three-step invasion. First, the patient breathes in the spores, and these things are literally everywhere in the environment. Second, once they're inside the body, the spores start to germinate and grow into their long, thread-like forms called hyphae. And third, this is the game changer. These hyphae are angioinvasive. They literally smash through the walls of blood vessels, causing blood clots and cutting off the blood supply. And what happens when tissue doesn't get blood? It dies and turns black. That's the necrosis.
Okay, so what makes someone a perfect host for this fungus? Here's a super high-yield and kind of unique fact. This fungus absolutely loves iron. It needs free iron to grow and go wild. This is a big deal because that's not true for most of the bugs you study. So the number one risk isn't just a weak immune system in general. It's any condition that basically serves this fungus an all-you-can-eat iron buffet.
And this slide shows you exactly who's at risk. The absolute number one must-know risk factor for mucormycosis is diabetic ketoacidosis, or DKA. So why is that? Well, in the super acidic state of DKA, a protein called transferrin, which usually locks up iron, can't hold on to it anymore. So it releases all this free iron into the blood, and boom, it's a feast for the fungus. Other big risks are things like renal failure, being on iron therapy, or anything that messes with your phagocytes, like neutropenia or being on steroids.
All right, now let's see how this all plays out in a real patient. The signs and symptoms you're looking for are a direct result of that angioinvasive nature we just talked about. The fungus just follows the blood vessels, leaving a trail of destruction behind it. The classic presentation, the one you'll see in textbooks and on your exams, especially in a patient with DKA, is Rhino-Cerebral mucormycosis. The infection kicks off in the sinuses and then just invades everything around it. You're going to see things like facial pain, a bad headache, and, this is the classic sign, a black, dead piece of tissue called an eschar on the inside of the nose or the roof of the mouth. From there, it can spread really fast into the eye socket, causing the eye to bulge out, that's proptosis, and then eventually into the brain.
Now, while the rhino-cerebral form is the one you'll hear about most, you should know the others exist. The second most common is pulmonary, especially in patients with leukemia. You can also see it on the skin, in the GI tract, or in a disseminated form where it just spreads everywhere. Okay, let's get into the lab diagnosis. This part is absolute gold for your exams, so listen up. I want you to think about it in 3 simple steps. You see it in the tissue, you grow it on a plate, and then you give it a name. See it, grow it, name it.
Step 1 is looking at the biopsy directly under the microscope. And this image? This is the money shot. You have to memorize these 3 features. First, the hyphae are broad. People describe them as ribbon-like. Second, they're aseptate, which means they don't have any cross walls or septa. And third, they have this really wide-angle branching, almost at 90 degrees. This is how you tell it apart from Aspergillus, which has skinny, septate hyphae that branch at a sharp, acute angle. Step 2 is growing it in culture. And these guys grow fast. I mean really fast.
We call them lid lifters because their fluffy, cotton candy-like growth can literally fill the whole petri dish and push the lid off. For Rhizopus, which is the most common one, you'll see this classic salt and pepper look, where the white fuzzy part gets these little black dots of sporangia all over it.
Okay, so you've grown a lid lifter. Great. Now you got to figure out exactly which one it is. How do you tell Rhizopus from Lactymia, from Mucor? It all comes down to one little structure, the rhizoids. They're these tiny root-like things, and where they are, or if they're even there at all, tells you exactly what you're looking at.
And here it is. This is probably the single most important memory trick for this whole topic. You have to commit this to memory. Ready? RLM goes with NIA. R for Rhizopus has N for nodal rhizoids. They're right at the base, at the node. L for Lactamia has I for internodal rhizoids. They're in between the nodes. And M for Mucor has A for absent, no rhizoids. RLM, NIA. Seriously, burn that into your brain.
And this slide shows you exactly what we mean by nodal for Rhizopus. On the left, you've got the simple diagram. On the right, you have the real deal, a slide stained with LCPB. Do you see how the stalk that holds the spores comes up from the exact same spot as those little root-like rhizoids? That's the nodal position. That is classic Rhizopus.
All right, let's wrap this up. We're going to talk treatment and give a final summary of the absolute must-know points for your exams. Because getting this diagnosis right isn't just an academic exercise. This is a true medical emergency.
So treatment is a two-pronged attack. You need both parts for it to work. On the medical side, the drug of choice is amphotericin B. You might also use alternatives like posaconazole, but and this is so important, you have to combine that with aggressive surgery. You have to physically cut out all that dead necrotic tissue. Why? Because the fungus has already blocked off the blood vessels, so the antifungal drugs can't even get there. The surgery is absolutely crucial.
So let's end on a clinical thought. You get a call. A patient with DKA has a black lesion on their face. The biopsy report just says broad fungal hyphae. Right away, your brain has to jump to the critical question. Are these the broad, aseptate, wide-angle hyphae of Zygomycosis, or are they the septate, acute-angle hyphae of aspergillosis? Getting that detail right isn't just about passing a test. The treatments are totally different, and making that call, starting with what you see under a microscope, could literally be the difference between life and death for your patient. And that's why this stuff really matters.